I don't know what they're doing across the hall, but I just noticed the whole room is gutted. So hopefully they're not too noisy. All right. So we're moving on into endocrine system. Endocrine system, really, we're going to be talking about chemical communicators. So the organ must release a chemical or a hormone, and then whatever the target tissue must have a receptor on it to respond to it. If the receptor is not there, it doesn't do anything. It's slower. It's not like your nervous system. Your nervous is very fast. Okay? On off switch. Whereas endocrine, it's slow. We release it into the bloodstream. It has to circulate around and get to the target tissue, hit the receptor to have a reaction. It takes longer and it lasts longer. Okay? So the effect is usually bigger, like more larger scale in the body. Like if you think about when you release epinephrine and norepinephrine, your blood vessels constrict, your heart rate increases, you start to sweat, your pupils dilate. So you see all these different effects all around the body. Whereas nervous, if I want to move my finger, I just move my finger and that's it. Okay. So endocrine system, like we were saying, hormones into the bloodstream. Where it's going to act depends on if the receptor is there. If the receptor does not exist, no effect. Okay. So we talked about diabetes insipidus, for example, and we said that's where they don't release ADH. And so they can't put aquaporins into their nephrons and they can't reabsorb water. Well, there's also another side of diabetes insipidus, which is called nephrogenic diabetes insipidus. They do not have the receptor existing in the nephron. So they make ADH, but since the receptor is there, can't do anything. So you can see situations like that. When you go further along in the pathology side, there are paraneoplasia. So it is these cancers, typically a lung cancer, and they'll secrete hormones. So the patient will come in and they're exhibiting these weird symptoms like, this overactivity of this hormone. And you start trying to figure out what's going on. And they do like a chest x-ray and they see a big old tumor. So there are situations like that. Like sometimes they'll release like insulin-like growth factor. And so it'll act like insulin on their body for no reason. All right, so nervous system, action potential, nerves, fast, short time versus endocrine. Hormones, they're chemical communicators, slow response, but long lasting. We need this because you couldn't run a nerve to every cell. We would be massive, right? We don't need that. It would just require too much energy. So having a chemical communication system makes more sense. So hormones are released into the blood. So they're secreted. So that's why we say crine. That's what crine means. So endocrine into the blood. Okay, secretion into the blood. All right. So when we talk about target cells, they must have the receptor. We can see cells that'll respond to like one hormone only, or a different hormone, or some will respond to both. And so when you talk about like hormones, you kind of think like yin and yang, there's a balance. So as we release one, we may negate the other. We may try and turn it off, or we'll just turn one way on and that's the response we'll get. The other one's still working, it's overridden by the first one. Or we'll see we turn off one. Well, now the other is exposed and we see that reaction. So the hormones can be released and activating on cells doing different things. So autocrine, that's the first type of cell signaling we look at. So this acts on the cell itself. Autocrine acts on the cell. So here they talk about like interferons released by CD4 cells act on other CD4 cells, for example, or T helpers act on other T helpers, or CD4 on other CD4. Interferon, when a cell is infected by a virus, it'll release interferon into its neighboring cell that's the same cell, or cell type, we should say, and teach it to avoid the virus. or prevent it from allowing the virus to use its ribosomes. Paracrine, this is acting on neighboring cells. So the example they use here is neurotransmitters. So neuron releases like dopamine. It acts on the next next neuron. Your alpha and beta cells in the pancreas, they act on each other. So when like insulin comes out, it acts on the alpha cell to turn off glucagon, and vice versa. Okay? And then general endocrine, this is, acting somewhere else in the body, releasing norepinephrine and the effect all around the body that we talked about. Amino acid-based hormones and steroid hormones. So what we're going to be looking at here is really, can they penetrate the cell membrane or not? So if it's hydrophilic, okay, hydrophilic, water-loving, so it's polar, it will not go through the plasma membrane. So what does that mean? The receptor is on the surface. So it's going to command something inside the cell to command the nucleus. So the example they give here is insulin. Insulin binds to the insulin receptor on the surface of the cell. It causes a secondary messenger, which is referred to as cyclic AMP, CAMP. You guys may have seen that. And that'll command the nucleus to tell the glucose transporters to open up and let glucose in. So if it's a amino acid, for the most part, there's like one or two we talk about that are not. They are hydrophilic. The receptor is on the surface, and that's of the surface of the cell, and that's how it communicates with it. So this is talking about the secondary messenger. That's what it's talking about. It's commanding the cell to do things inside of it. So secondary messenger, that's cyclic AMP. Usually it's written like a lowercase c and then the AMP capitalized. Oh, there it is. Okay, that's secondary messenger. It's kind of like a relay guy. So when that hormone strikes the cell membrane, he relays to the nucleus to tell it what to do, right? So that's what they're showing here. So we'll say that's insulin striking the cell membrane, the receptor there, and then we activate that secondary messenger, which tells the nucleus to do certain things. Here's our exception, T3 and T4. They're amino-based, but they are nonpolar. So because they're nonpolar, they can go through the cell. So when we look at, the thyroid gland and how we store T3, T4 in there, well, we got to attach it to something that is polar. Otherwise, it would just flow out. So we stick it to a protein. All right. But T3, T4, T3 is the active version, T4 is not, but our bodies can convert it to active form. So these stimulate, activity in the body, metabolism. They up the metabolism. So because they're nonpolar, they're small, they can slip through. Their receptor is on the surface of the nucleus, on the nuclear membrane. Steroid hormones, so they're fats. So they're hydrophobic. They're nonpolar, made from cholesterol, okay? All the receptors will be on the surface of the nucleus or inside of the cell. So these can pass through the cell membrane and then directly command the nucleus to do things. So here they're showing this would be a hydrophilic. The receptor is on the surface. Hydrophobic, it can enter cell receptor in the nucleus or on the surface of the nucleus. All right. So this chart here, this is how you're going to learn these guys the easiest way, in my opinion. You're going to create 3 boxes. So box 1 will be hypothalamus. Box 2 will be pituitary. Box 3 will be the organ. So what happens here when we want to release certain hormones? The hypothalamus is the command center. It's going to tell the pituitary to release the hormone. So it releases, the hypothalamus sends a releasing hormone through to the pituitary. The pituitary then will either go into production and release the hormone, or it'll release stored hormones. Then those will go to target organs, and the organs will then produce the actual hormone that we see in the bloodstream. The first two, the first one you will not see in the bloodstream. The releasing hormone from the hypothalamus you will not see in the bloodstream. We can't measure it because we'll see there's a portal system between the pituitary and the hypothalamus. It goes straight in there. It's used. That's the end of it. Once the levels of the hormone that we see in the body that we traditionally, measure, like T3, T4, for example, once those levels come up high enough, it'll turn the hypothalamus off. It'll turn the pituitary off, which then the organ will turn off. So that's negative feedback. As those hormone levels come high enough, we turn off hypothalamus, we turn off pituitary, the organ turns off, and we stop producing the hormone. Once levels drop low enough, it'll turn back on, and we'll start producing. Positive feedback, you guys learned about this in AMP1. This is like oxytocin, for example. When a woman goes into oh man, why did I just blank? She's delivering a baby. Labor. You know what's bad too is my sister just gave birth to a kid yesterday. I should know what labor is, right? My sister is special too. The oxytocin, when it's released, it causes the uterus to contract. As the uterus contracts, it causes more oxytocin release. Same thing when you talk about with like breastfeeding. As the baby breastfeeds, the brain releases more oxytocin. The hypothalamus commands the posterior pituitary to release it, not produce it. Okay, release it, and the milk release continues. So I got to show you guys a picture. This is what they sent us from the hospital yesterday. My sister just going to town on some sushi right after having the kid. Can't have it while you're pregnant, so she went to town. Hello. All right, prostaglandins, these are hormone-like substances. They come from arachidonic acid. These are going to be hydrophilic or polar substances. And so we've talked about thromboxane, right? Vasoconstriction, clotting, prostacyclin. We talked about this. This prevents cells from sticking to the surface of your vessels. And leukotriene, these are communicators between like white blood cells. That's their communication system. One type. All right, so pituitary gland, that's our second box. We call him the master hormone gland because he produces a majority of the hormones that we talk about. His proper name is the hypophysis, and he's a puppet. The hypothalamus is truly controlling him. And so it is sending through the infundibulum, that's the little stalk the pituitary hangs from, through the portal system there, releasing hormones, and he's controlling the pituitary. So it's funny, we're talking about this today, and my wife was talking about how they like fluid overload women when they go into labor, or like right before going into labor. And the reason is when a woman delivers the child, there is a sudden plasma reduction. And what happens is that infundibulum all of a sudden goes and chokes the pituitary and self-infarcts. And so what will happen is they'll be producing like milk and suddenly stop. That's it. The pituitary dies. They don't produce all their hormones. They have to go on hormone replacement therapy for all the missing hormones. Big problem. So they fluid overload to prevent that. Another reason we shouldn't deliver babies at home. It's like it's a thing that's becoming more popular now, where women will want to deliver child at home and do like water births. Not wise. Not wise at all. High risk of meningitis because all the E. coli gets into the baby as they're delivering. What if the cord wraps, stuff like that, situations, emergency situations. There can be postpartum hemorrhage, postpartum infection. And then you get into the whole like they're not getting fluids, so they can infarct the pituitary. A lot of risk factors there. It's not wise. Hospitals will actually let you do water births in them now. A lot of them will allow that. I remember I was on rotations and it was like 3 o'clock in the morning, and me and another student were standing on the L&D floor, and this lady comes out of a room. She goes into the general bathroom. She comes out in a bathing suit, and she's not pregnant. I'm like, wait, what? And the nurse looks at it. She's like, oh yeah, she's getting in there with the lady that's about to deliver. I was like, that's nasty. uh, you can sit next to him. You don't have to get in there with him. Anyhow, so hypothalamus, he's the control center. He is sensing everything, sampling everything, controlling everything. If you remember, he's linked with the limbic system. So that's why, you smell apple pie and you think of grandma's apple pie. It takes you back. It's a memory, good feeling. That's where we associate good things and bad things with emotions. Appetite, thirst center. So we're controlling that, temperature regulation. We've talked about all of these, AP1 here, okay? But the big thing that we're going to focus on here is the connection between it and the pituitary and how hormone release can be affected by that. So, when women breastfeed, for example, and oxytocin is released, oxytocin also causes the good feeling or like feeling happy and like cuddly. I don't know how to describe it. All right. And so what happens is because of that oxytocin, they relate this good feeling to what's happening. And so a lot of times that's why you'll see like they go through labor, it's incredibly painful. And then afterwards they're like, let's have another. Right. Or it's very hard sometimes for them to stop breastfeeding because there is this soothing sensation they get because of the oxytocin release and the connection with the limbic system. So we're going to go through all of these. You'll notice for us, we're going to say all the purple ones plus this white one are produced by the anterior pituitary or the adenohypophysis. The posterior pituitary only stores hormones. It does not produce hormones. The hypothalamus makes them, releases them in vesicles, and then when it's time to release them into the body, it sends a nerve impulse through and causes it to be secreted out. But the posterior pituitary does not produce hormones. The neurohypophysis does not produce hormones. And the two that we look there are ADH and oxytocin. That's the only two, okay? So anterior pituitary, adenohypophysis, 7 different hormones we'll look at. And then posterior is the neurohypophysis, doesn't make any hormones, it just stores oxytocin and ADH. So here's anterior pituitary, posterior pituitary. When you guys look at these cells, every time I look at a slide, it's stained a little different. So the trick here for lab is to identify the difference in like the structure, if you will, or how it's staining. So chromophobes, the cytoplasm and the nucleus does not stain well. Chromophobe, color fear, okay? Acidophil, the cytoplasm stains well, but the nucleus doesn't. Basophil, both stain very well. So it tends to be dark nucleus, dark cytoplasm. All right, the portal system. So hypophyseal portal system. Remember, a portal system is a vessel between 2 capillary beds. So we have capillary bed in the hypothalamus, capillary bed in the pituitary, and that's how it communicates. So the releasing hormones will travel through there. We won't see them in the bloodstream. They'll be consumed by the pituitary, and that's the end of them. Okay? So we have growth releasing hormone, or growth hormone releasing hormone, I should say. And so when that is released from the hypothalamus, it'll go down to the pituitary and will make growth hormone, for example. Inhibiting hormones, those stop things. So releasing hormones make the pituitary make things. Inhibiting hormones make the pituitary stop. So here they're showing the portal system, and that's how it would communicate. And then the posterior pituitary is controlled through nerves, neurons, right? So anterior pituitary, first hormone we look at, TSH. So that's a thyroid stimulating hormone. That's going to go to the thyroid and make him make T3, T4. ACTH, adrenocorticotropic hormone, we're going to see has a couple different effects we'll talk about. Gonadotropic hormones. So these work on other, the tropic hormones, these all four. These work on other endocrine organs. So the other organ will produce hormones also. So the gonadotropic ones, these work on the gonads. We have luteinizing hormone and follicle stimulating hormone. So these first four act on other endocrine glands or organs. So when TSH comes down, we make thyroid, we go to the thyroid, we make thyroid hormones. Okay? Non-tropic, so these act just on regular tissue, so like growth hormone acts on bone. Prolactin, it acts on breast tissue. MSH or melanocyte stimulating hormone acts on the melanocytes in your skin. Okay. So first hormone we look at, growth hormone. Children release a lot of growth hormone. So think about like what is a kid? Skinny, growing rapidly, right? So they're building structure. So when you look at growth hormone, lipolysis, the breakdown of fat, the protein anabolism, they're building protein structure. Increased blood glucose levels because they needed to produce ATP. Okay. There's insulin-like growth factors, which are somatidines, and these also work on growth. So we give growth hormone to like premature kids. That's frequently when we give it to, or kids that are just not growing at peak growth. They're not in the growth range that they should be in. So we administer growth hormone. It's an injection that they take, and it can catch them up to, children of their size, their age. So the problem with that is, let's say you get too much growth hormone as a child. You have like a pituitary adenoma. So that's a tumor of the pituitary. It makes it oversecrete. So before the epiphyseal plates close, you get gigantism, excessive growth. If you don't produce growth hormone, then you get dwarfism, right? So this is before the epiphyseal plate closes. If it happens after the epiphyseal plate closes, we see what's called acromegaly. This dude is so tall. He was I think the tallest person ever. He's like over 8 feet, something wild like that. So here's acromegaly. So this was before, this is after. So they produce growth hormone as adults. This is after the epiphyseal plate closes. What they'll come in complaining is like gloves don't fit anymore, hats don't fit, shoes don't fit. There's been a sudden change. They tend to get what's called like frontal bossing. The plates here grow more, jaw grows, voice deepens. They develop diabetes, stuff like that. So typically it's due to a tumor. And then the pituitary adenoma, it's pretty neat. Little side topic here, but they develop peripheral blindness. They lose the periphery, so they'll come in. Another symptom of this is they come in and they keep on running into walls, like doors, like the door frame. They don't see it, or they get into car accidents and they say, I never saw the car coming from the side. And the reason for that is the pituitary sits above the optic chiasma, where the optic nerves cross. And so as that tumor grows, it starts to compress it. And the way it compresses it, you lose the inner tracts, which is your periphery. And so that's a sign that they have that. It's pretty wild. So prolactin acts on the breast tissue to maintain milk secretion. Okay? Maintain milk secretion. Prolactin is to release milk. So sometimes when we give certain medications, psych meds, they cause, let's see if I can remember this right, increase in dopamine, which causes an increase in prolactin. Sounds right. Sounds right. I could be wrong. Could be the other way around. And so women will start randomly just producing milk or releasing milk. Right? So that is like a side effect with some of these drugs. So here what they're showing is, here's hypothalamus. Hypothalamus produces the prolactin releasing hormone. It acts on the pituitary. Then we stimulate the prolactin. That acts on the breast tissue, and we produce or release the milk. As these levels get very high, it would turn on the inhibiting and turn off the releasing, and we shut it down. Oops. Okay. MSH, so this acts on skin, helps darken up the skin a little bit. They produce more melanin. The thought is with this and melatonin production, there's like a role, like a connection here, and like our vision in our like light in our eyes has an effect on it. And that's when you get into like talking about like melatonin for like sleep cycles, stuff like that. That you should be in a bright room or bright area during the day, and at night, complete darkness, to stop or to change the production or produce it at night. TSH, so thyroid stimulating hormone. So hypothalamus will make the releasing hormone. That will travel to the pituitary. The pituitary will make TSH. That'll go to the thyroid. Thyroid will make T3, T4. When T3, T4 levels get high enough, hypothalamus shuts down, pituitary shuts down, thyroid shuts down. As levels drop, hypothalamus will turn back on, release the releasing hormone. The pituitary will turn on, release the stimulating hormone. Thyroid will turn on, and levels will come back up. Our bodies are very good at regulating these levels. When we start to see anomalies, something's wrong. It's not normal for someone to come in with high T3, T4. Something's wrong. Either they're taking Synthroid when they shouldn't be, or they have like a hot follicle in the thyroid, like a cancer, potentially. Okay? Or they have Graves' disease. That's another way they could have it elevated. So this is what I was talking about with like the boxes. You always do the hypothalamus, what he's releasing, the anterior pituitary, what he's releasing, and then the target tissue, and then we talk about the negative feedback. So that's how you guys want to learn these. So T3, T4, when it gets high enough, it's going to turn off the hypothalamus. If it's low, hypothalamus will turn on, right? So T3 requires iodine to produce it. So that's why like you should be getting iodinized salt. That's the reason for that. Without it, you'll develop goiter. You'll have a massive thyroid because it's being overstimulated because there's not enough T3, T4. The hypothalamus is just constantly trying to trigger it. The pituitary is trying to trigger it. And literally they'll come in with a big old lump like this. It's interesting how they discovered it back in the day. It was nomads in the desert. The people that like travel oasis to oasis. And because they weren't getting iodine in their diet, they all had goiter. So that's where they discovered it. So iodinized salt. It's good for you. All right. So if there's not enough iodine, not enough T3, T4 will be produced. Hypothalamus will release the releasing hormone. That'll stimulate the pituitary to release TSH. That'll stimulate the thyroid and make T3, T4. Okay? And then there's the goiter if we can't raise it. That is a ridiculous amount of goiter. That's just not even remotely normal. There's something else going on there. Okay? Usually it's like a little lump. So that's part of the reason why you go in like physical exam. We'll feel around, feel the thyroid, feel if it feels large. That can be a sign. Okay. The other symptom, if they have like, heart arrhythmias, heart accelerating, weight loss, stuff like that, that can be a sign of overactive thyroid or production of thyroid hormone. And then we would see like elevated TSH levels, elevated T3, T4 levels. That's signs of it being overactive. Okay. When someone has low thyroid hormone, you see the opposite. They weight gain, they feel cold all the time, their hair thins, stuff like that. So that's typically called Hashimoto's disease. It's autoimmune. And we give them Synthroid. Synthroid is dosed in micrograms. Most medications you talk about are milligrams and grams. This is micrograms. And they constantly monitor it and adjust it. Because too much, they'll have heart arrhythmias, heart attacks, stuff like that. Graves is the other end of it. That's the overactive. It's also autoimmune. You may have seen it on TV recently. They've been doing a lot of advertising for medication to reduce TED, thyroid eye disease, because their eyes literally, they get like a sugary protein behind their eyeballs and it starts to push their eyeballs out of their sockets. So that's what they keep on advertising on TV, where the lady's always wearing like the glasses and then finally she takes the sunglasses off. That's TED. Okay. Adrenocorticotropic hormone. So here we have the hypothalamus releasing the cortico-releasing hormone. There's our ACTH from the pituitary, and then it acts on the adrenal gland to release glucocorticoids. So it's going to produce cortisol. That's what we're going to see. Elevated cortisol levels as they come up. We should turn everything off. We have that negative feedback. So cortisol, corticosteroids, personally, I'm not a huge fan. There is a place for them, but like some people just overprescribe it, especially pediatricians. Everything, they're like, steroid. That's not good, okay? Steroids demineralize bone. They weaken the immune system. They cause weight gain. They cause glucose production. So they can cause like temporary diabetes or A1C elevation in patients. So there is appropriate times for them. Like, for example, my wife's niece, she caught like some nasty cold for a while, cleared it, and for 2 weeks later, she still has this nasty cough. Well, she has a little bit of like an asthma, inflammation in the bronchioles. Fine, we'll do a little bit of an inhaled steroid. Inhaled steroids also stunt growth. So they're not like the best thing to be used all the time. To give you an idea of how much they demineralize bone, when I first started teaching, and I was teaching an AP1 lab, and I was showing them the femur, and I was like, this bone does not break. Like if this bone breaks, that person was like in a bad MVA, a motor vehicle accident or something like that. Like you don't break femurs that easily. And this little kid in the back of the room, he's like, I broke mine. I was like, how did you break it? He's like, my brother fell off the bed onto me. I was like, are you taking steroids? He's like, yeah, I've got Crohn's. So because of his Crohn's, they're giving him steroids to prevent the inflammation. It demineralized his bone that much that he broke it that easily. Like the femur, a break of a femur is no joke. It's actually kind of dangerous because there's so much like fat or yellow marrow in there that it comes out and it can actually cause a saddle embolism of the pulmonary arteries going into the lungs and kill people. It's super dangerous. So, yeah, we'll give Medrol packs every once in a while. That's appropriate sometimes, but tell you, pediatricians, every time a kid's sick, oh, here's steroid, it's too much. It's not really appropriate. The problem with it is we produce our own. So when you give someone a steroid, you give them a big whomping dose in the beginning, and then you wean them off. You have to do this because what happens is the body's lazy. Anytime you give the body an exogenous supplement, you give it an outside hormone or anything really that it produces, it's going to stop making it because the body is lazy. It's like if you use artificial tears all the time, you will stop making tears and your eyes will feel horribly dry all the time until you just cold turkey it for a week or two and then you'll start producing tears again. When a male takes testosterone, they stop making testosterone. There's no need to produce it if I'm getting it for free. So same thing with cortisol. The adrenal gland will stop to produce it if you immediately cut a person without tapering them off the steroid. They will have an adrenal collapse. Their vascular system will not have appropriate pressure. They literally will go into a hypovolemic shock. So that's why Medrol packs are dosed to where you step down. It's safe to take the big whomping dose. That's fine, but you have to tear down, okay? So you'll see like a lot of medications where we do that. We get up to real high doses. Anytime we're going to pull the patient off, you wean them. You don't just cold turkey them. The body, not good, okay? It's kind of like someone trying to stop smoking. You've been giving them that stimulant, the nicotine, which is stimulant, and they try and cold turkey. It's tough. Cold turkeying is tough in that situation. You try and get them stepped down. So that's where like kind of like vaping came about from. Was like, oh, you can control the amount and step them down, step them down, step them down. But what are people doing instead? They're just vaping for the sake of it now, right? So bad. My wife had one come in. It was back when there was like a bad batch that came out of China or something, and the kid was like 20 or something, 22 years old, needs a double lung transplant, lung failure from vaping. Silly. All right. FSH, LH, both males and females have them, the hormones, but they do different things. Okay. So in LH, that causes ovulation. So luteinizing hormone causes the egg to leave the ovary. This is approximately, we're going to go through this in detail, approximately 14 days before menstruation. FSH, follicle stimulating hormone, this is what causes the egg to begin to develop. So the woman is born with her eggs. They're going to be called primordial follicles. When FSH comes down, it stimulates that primordial to start developing and maturing. To finish meiosis is what it's doing. Once it's large enough, it actually stimulates the brain through the release of estrogen to release LH, which causes the egg to exit the ovary. The male, luteinizing hormone, causes testosterone production. FSH causes formation of sperm. So negative feedback, when the egg makes estrogen, it stops FSH. So this is why we use estrogen and progesterone to stop the release of FSH. That's contraception. By stopping the release of FSH, the woman does not ovulate. She does not produce an egg. She does not ovulate. On the other hand, when you talk about like fertility drugs, that's what we're giving. We're giving FSH, and then we give LH, and that causes the eggs to release. The problem with this is sometimes a lot of eggs release because of the doses we're giving, or they capture the eggs and then they implant a bunch, and that's how you end up with like Octomom. That's where that comes about. Really, over twins is they're using fertility drugs. Even twins, usually they're using fertility drugs. So I have they're two brothers. I grew up with them, and one of them has twins. The older one has twins. And his younger brother, I saw him, we were at a mutual friend's wedding last year. He had a few adult beverages. He comes up, he's like, Peter. Like, what? What, John? He's like, they had to use fertility drugs. That's why they have twins. We don't have any twins in our family. I was like, oh, why'd you tell me this, dude? Okay. Like, anyhow. But yeah, if the woman does not have twins on her side, usually that's what's happening. They've used fertility drugs. It comes from the woman's side because it has to do with the egg release and division of the egg. That's really where twins come from. Okay. We used to do straight estrogen. We discovered that's really bad. that causes cancer. So we don't do straight estrogen anymore. It's very low dose estrogen with progesterone. And some are straight progesterone as far as contraception. There's a lot of myths out there about contraceptive agents like weight gain. No, not really. I mean, a little bit, but it's water. Because you have more solute in there, you're producing these hormones and proteins and stuff. And so water, that's fine. Minimal. The other rumor or myth is that if you take contraceptive agents that you'll have difficulty getting pregnant. Not true. Will it take a month or two for your cycle to go back onto its normal schedule? Yeah, but that's it. There's no like negative effects down the road. There's actually correlation with reduction of cancer by taking contraception now that we're doing the correct types. And then there's IUDs, and those just agitate the lining so the egg can't implant. So that's like your copper. And now they have like Mylena and Kylena. Those are drug-eluting ones. So they release estrogen, progesterone, and protect. Straight progesterone isn't always the best because it also demineralizes bone. So it's not the wisest to do. But yeah. So in the males, so here, FSH is going to help make sperm, and then LH is making testosterone. So as the levels are appropriate, we'll have negative feedback on the hypothalamus, and we'll turn off LH. And we can see even with FSH, when it decreases, sperm count decreases. So we've gotten in this bad thing lately in the medical world where we're just writing testosterone, low T. I'm sure you've seen it on TV. They advertise, and they're pushing this like, oh, you feel a little down when you're 40-something years old. You need testosterone. Not wise. The problem with estrogen, testosterone, they stimulate the liver to make clotting factors. So there's a risk in itself. The next thing is how you apply testosterone for males. It's not an injection. It's like a gel that they put in their armpits, and it's absorbed through the skin. So it's dangerous because if a female touches it, now she's getting exposed to testosterone. If she's pregnant, the fetus is getting exposed to testosterone. So it's not wise. In reality, we can verify that a woman is going through menopause by her FSH levels. They skyrocket because there's no negative feedback from estrogen from the egg production. Why are we not looking at that in males? We should be able to look at FSH and go, well, if your FSH is skyrocketing, that's because there's not a negative feedback there. Yeah, your testosterone is too low, right? Or your LH is too low, and that can be monitored, right? LH is what we monitor in women for ovulation. So when they get the ovulation test to see if they're ovulating, that's what they're seeing in their urine is LH levels. All right. How are we doing on time? Oh, we are good. So the posterior pituitary, remember, it does not make anything. It just stores ADH and oxytocin. So the neurons that are up in the hypothalamus produce it, the neurosecretory cells. It's then in vesicles, and there's these long axons that travel down. And when it's time for the hypothalamus senses like osmolarity of the blood is getting too high, it's too salty in here, there's too much solute, let's release ADH. It will send a nervous signal down, and ADH will be released into the blood on the nephron. Same thing with oxytocin, okay? Remember, posterior pituitary does not produce anything. It just stores the two and is released when hypothalamus commands it. That's what they're showing here, okay? ADH, also known as vasopressin, we talked about this, works on the nephron, the ascending loop of Henle, the DCT, and the collecting duct. It allows us to reabsorb water and would concentrate the urine or increase the osmolarity of the urine and decrease osmolarity of the blood. Who's controlling it? Hypothalamus. What is he measuring? Osmolarity or saltiness of the blood. In diabetes insipidus, either they're not producing ADH, There's something wrong with the pituitary, or they produce it, but they don't have the receptors for it in the kidney. And so either way, it's diabetes insipidus. Central is the one where they don't produce it. Nephrogenic is the one where they're lacking the receptor. It has nothing to do with glucose levels. It just has to do with excessive urination. Oxytocin, once again, not produced by the pituitary. It's produced by the hypothalamus. It works on the uterus and the mammary glands. So during labor, when the uterus is stretched, it causes positive feedback. More oxytocin is released. So when we induce people, women, and we cause them to go into labor, we're giving Pitocin, which is the synthetic version. That's what we're giving. Okay, breastfeeding, as the child breastfeeds, that causes the milk secretion or letdown reflex. That slide about prolactin is wrong. I thought it was. Prolactin is to produce milk. Oxytocin is to release milk. Make sure you guys correct that. Prolactin is produce milk. Oxytocin is to release milk. Okay. So as they continue to do that, they can release the milk. Don't we have like 2.5 days to complete this? Let's see. Let me look at our schedule. Like, we've made a good dent in it. Yeah, we have 2.5 days. I'm gonna stop here. I think it's a good stopping point. We're halfway through. Okay? Any questions? No questions? All right. And then Cecilia, I'm gonna shoot you an email in a second here. Just be on the lookout for it. All right. Enjoy the rest of your day. I'll see some of you in lab. If not, I will see you on Wednesday.